Today we'll discuss the fundamentals of brain tumors, a critical topic in neurologic nursing care, especially when dealing with oncologic and degenerative disorders. I want you to really focus on understanding how these conditions show up, how they're diagnosed, and how we care for patients from admission through recovery. The nervous system is complex, and when it's impacted by tumors or degenerative disease, it presents unique challenges. Nurses caring for these patients must understand not only the disease process, but also the diagnostic tools, medical management, nursing priorities, and long-term rehabilitation needs. We care for these patients in both inpatient and outpatient settings. And we don't just care for their physical symptoms. We support their dignity, cognition, and often their family members too. We'll begin by looking at brain tumors, which are one type of oncologic neurologic disorder. They can be either primary tumors that start in the brain or secondary tumors, also called metastatic lesions, that spread from other organs. Common primary tumors include gliomas, meningiomas, acoustic neuromas, and pituitary adenomas. A brain tumor is basically an abnormal mass of tissue that grows within the skull. It can cause symptoms in three main ways: by increasing intracranial pressure, by directly invading or compressing brain structures, or by disrupting hormone or nerve function depending on where it's located. Even benign tumors can be dangerous if they're pressing on important structures. Tumors are categorized a few different ways. We have intracerebral tumors like gliomas and astrocytomas, tumors from supporting structures like meningiomas or neuromas, developmental tumors like dermoids or angiomas, and metastatic lesions which spread from cancers such as lung, breast, or melanoma. Let's break a few of those down. Gliomas are the most common type of brain tumor in adults. These grow from glial cells which support the brain. The most common subtype is the astrocytoma, and the most aggressive version is called a glioblastoma. That's grade 4. These tumors tend to invade nearby tissue, making them hard to remove completely. Meningiomas are usually benign and slow-growing. They're common in middle-aged women and can compress nearby structures without invading them. Acoustic neuromas grow on the 8th cranial nerve and often present with hearing loss, tinnitus, and vertigo. As they grow, they can press on other cranial nerves and affect facial sensation and movement. Pituitary adenomas can cause problems either by putting pressure on nearby structures like the optic chiasm or by secreting excess hormones like prolactin or growth hormone. A patient with excess prolactin might have amenorrhea or galactorrhea. Growth hormone excess can lead to acromegaly with enlarged hands, feet, and facial features. Let's talk about the clinical manifestations. These depend on where the tumor is and how fast it's growing. Common generalized symptoms include headache, especially in the early morning, nausea and vomiting, sometimes projectile, seizures, visual disturbances like double vision or vision loss, and papilledema, which is swelling of the optic disc. Focal symptoms depend on the lobe or structure affected. Frontal lobe tumors can cause personality changes or motor weakness. Parietal lobe tumors can cause sensory loss. Temporal lobe tumors may present with seizures or mood changes. Occipital lobe tumors can cause vision loss. If the cerebellum is involved, you might see ataxia and dizziness. And if the brainstem is affected, you may see cranial nerve deficits and vital sign instability. To diagnose brain tumors, we start with a neurologic exam and imaging. The most common tools are MRI, especially good for brainstem and pituitary tumors, CT scans, often with contrast, PET scans, which help distinguish tumor grade, and stereotactic biopsy to sample tissue. Other tests might include EEG to detect abnormal brain activity and CSF studies to check for malignant cells. Now let's look at treatment. Surgery is the first step for many tumors if they're accessible. The goal is to remove as much tumor as possible without harming vital structures. Radiation therapy, like external beam radiation or stereotactic radiosurgery, is used when tumors can't be removed completely or are too deep. Chemotherapy, especially temozolomide, may be used alone or with radiation. It's one of the few drugs that can cross the blood-brain barrier. There's also a newer approach called tumor treating fields, which uses a wearable device to disrupt tumor cell division. Corticosteroids like dexamethasone are used to reduce brain swelling and help with symptoms like headache or altered mental status. Anticonvulsants like levetiracetam or phenytoin may be used to prevent or treat seizures. This is where we shine. Our role is essential. Here's what you need to remember. Assess pain and headache patterns. Use upright positioning and medications as ordered. Watch for seizures, even if the patient doesn't have a history. Educate families and ensure meds are taken correctly. Prevent aspiration, especially in patients with cranial nerve dysfunction. Evaluate the gag reflex and assist with safe eating strategies. Monitor neurostatus and ICP. Space activities to reduce spikes in pressure. Watch for side effects of corticosteroids like hyperglycemia, electrolyte imbalance, and muscle weakness. Support cognition with reorientation tools like clocks, calendars, and personal photos. Assess motor and sensory function. Work with PT and OT to maintain independence. Educate and support families, especially caregivers of patients with metastatic brain tumors. Their stress is real and deserves care too. Brain tumors demand attention, not just for their complexity, but for the way they affect the whole person. From diagnosis to treatment and through rehabilitation, nursing care makes a measurable difference. Whether you're caring for someone post-op, managing seizures, educating a caregiver, or adjusting the environment to prevent falls, you are a vital part of the treatment plan.